Well, baby, you've been on my mind. I think about you all the time. Oh, I want to see your face. That don't make me wait.
Cheers. Welcome to Sleeping Around the Podcast with Dr. Ann and Matthew. Today, we're going to rename the show. I don't know if you knew this. I didn't even ask your permission or talk to Handsome Dan, but we're going to call it Sleep and Shame. I'm just kidding. Sleep and Shame is going to be the topic today. But before we get started, I hate that you guys don't have a visual, but if you're listening in, I challenge you to go to our YouTube page, Sleeping Around the Podcast. Please like and share, subscribe, but you're going to want to see what Ann is wearing. Ann got all dressed up for a very important day today. I'm a little embarrassed to admit this, but Ann is going to be receiving the very first annual Matthew Allard Award. This is a very prestigious award that I had sculpted in South Africa, had shaped here. If you look, it is the exact size of my bald head. Mm-hmm. I asked them to taper off the ears, and I think they did a very good job. And it's a very heavy award. I'm sure you have plenty of awards.
Thank you.
Is there a speech that you would like to make thanking me for everything?
Yes, first I would like to ask all of the people who have helped me to get to this point in time. No, I'm just kidding. Thank you, Matt. I really appreciate this very, very heavy award. If you could please take it back before I injure myself or anyone else.
So actually, this is not an award at all. I saw it in the lobby, which I will be returning. And I said, man, if I had a long neck, that would be me. If only I didn't talk so much, so they would do that. Yeah. Today we are going to talk about a topic that a lot of men don't like to talk about.
Or women or anyone else who lives in the United States or internationally.
I'm such a big fan of Brene Brown, and to me, she has brought the word shame to the forefront on how to deal with it. As someone who is almost 50 years old, growing up, I have dealt with things in my life where I have felt shame and didn't know how to express it. I'm a man. Get up and go to work, get up and go to school, get up and do these things. One of the things, Ann, that you have taught me in the very short time that we've been friends is shame around sleep. Mm-hmm. And then it like a trigger went off in my head, and I remember going, oh my gosh, when I was selling CPAPs for Philips, that's exactly why men and women weren't wearing it. There was a shame. And the more I dug, and it's like the onion peel. Mm-hmm. And so today, and this is all Ann, I give her credit, what we'd like to do today for our audience is kind of walk through the different age ranges, different groups, and talk about shame and sleep. And how that is effective. And if you think right now and you're listening in and you're like, man, that's not me or that's not someone I know, listen to some of what Ann is talking about. We're going to be throwing statistics at you guys that's going to blow your mind. And for the men listeners out there, when we get to the point about erectile dysfunction, no jokes, it is staggering between that link and OSA, and you want to talk about shame. So I wanted to start off with giving you an award. Start off with talking about our friendship, but definitely want to dive into this. As goofy as I can be, I really take this topic very serious.
Yeah, and I think that it's one that I've been humbled by working with the advocacy organizations and how much that they do want to combat this idea as well, right? And so there's a lot of shame as well as stigma around sleep and sleep disorders. Right. And really, we're a society who brags about what we can do or how we curtail sleep to do more, right? And the reality is that this is based on just historical facts. Mm-hmm. When you look as early as 400 BC, when people were first starting to characterize sleep as anything as a part of the medical historical context, very frequently it was being referenced as a period of time of inactivity. Right. If I talk about inactivity, is that contributing at all to something that is positive? Absolutely not. No. So right there, we're already stigmatizing and shaming it as something that is optional. We don't need it. And this challenge is despite the fact that it was in the 1920s when we first developed EEG, so that's electroencephalogram. That's when we put the stickies on the head to look at what is the electrical activity of the brain. And we started to identify that sleep actually is not in an active state. It's quite active. And then in the 1950s, we started actually characterizing the different stages of sleep. We were identifying things like REM sleep and non-REM sleep. That still didn't change his mindset. Even into 1989, there were researchers who were still saying, okay, well, sleep might be necessary, but I think there's optional parts of sleep that we could probably get away with less of.
Wow.
And what's fascinating, in that same year that we had researchers on this side of the stage, we had Dr. Rekshiffin and his research crew, which one of his research crew was actually Clete Kashida, who's at Stanford, great friend, incredible researcher, huge advocate in sleep, who did these tremendous animal models that clearly demonstrated, whoa, we have been mistaken.
Right.
In 1989, they did a series of animal model research where they subjected these animal models to a variety of different sleep deprivation stages. One of them was absolute sleep deprivation. You were not allowed to sleep whatsoever. The second was a selective reduction of sleep. So they went and they said, okay, they're not only going to get this much stage 1, stage 2, stage 3, REM sleep, and then a final was progressive sleep deprivation. You want to know what they found?
What's up?
Those who were absolutely sleep deprived, so rodent models that were absolutely sleep deprived, died within 2 to 4 weeks.
Wow.
Okay. The next group, they selectively reduced the different stages. You want to know what happened now?
Yes.
They died within 4 to 6 weeks.
Jeez. Okay.
The last group, they had progressive sleep deprivation, 15 minutes, 30 minutes, a little bit longer, a little bit longer. Those didn't die immediately. What they did is they experienced a hypermetabolic state. I ate more, still losing weight. They then developed hypothermia. They were unable to control their temperature regulation. They then developed some ulcerations of the skin and of the GI tract, which ultimately resulted in an infection, an overwhelming infection, and died of sepsis. So in their experience, they had a slow and torturous demise and ultimately death. And so this isn't to fearmonger and say, if you don't sleep, you're going to die.
Right.
What it is to demonstrate and prioritize the fact that sleep is a homeostatic process, meaning it's something your body must do. And when you try to curtail it, you try to change it, you try to ignore the fact that you're getting it at the wrong time, it's poor quality, and you feel horrible during the day, you're not going to be your optimal you. And instead, what we've done in medicine is we have glamorized it, wearing a badge of honor of, I slept for 4 hours, I did this many surgeries, X, Y, and Z. Right. We glamorize the lack of sleep as something that people who are highly successful, they don't need it because they're stronger, they're smarter, they're faster. The reality is that when you talk to people who truly are successful, whether it is athletes, you look at people like Michael Phelps, he prioritizes sleep. That's a part of the reason why he is an Olympic champion. LeBron James, he prioritizes sleep. That's why he is an NBA superstar. We look at these individuals and we go, sleep is important. The same thing is true as we've said this on one of our other podcasts. You look at someone like Jeff Bezos, multi-billionaire. He prioritizes sleep and he makes sure that he utilizes that as a skill set to be able to make the best decisions for his business and to be able to be his best him when having to make those decisions.
I find it interesting. When I was, it hit me probably, I don't know, about 6 years ago, started thinking about it because I'd already been in sleep, but yet sleep deprivation is something, number one, used for our military.
100%.
We probably shouldn't bring up Guantanamo Bay, but sleep deprivation. And so here we are talking about shame. And how does that play a part? And I love, again, having you on the podcast is amazing with the statistics. But let's start as a child. Why would a child have shame, and I'm doing air quotes for our listeners, around having sleep issues?
Sure.
And what does that look like?
Yeah, so I would say that many times, how do people experience shame, right? It's not something that is innate to us. We're not born in knowing that there's activities or things that you can engage in and that there's a negative emotion that should be associated with it.
Right.
That comes from a social construct. And so when you're talking about an early childhood experience, most of those social constructs come from the home. And so parents are trying their best every single day, but children don't come with an instruction manual. We always joke about that.
No, they don't.
And the reality is that one of the things that parents really can struggle with is that putting a child to bed, right? And so when we're talking about early childhood, very frequently we encounter something called behavioral insomnia of childhood. It's a very different entity from insomnia that is in older child, the adolescent, or the adult, where there's other factors that are driving why they're not going to sleep. Right. The two main things for a child having difficulty being able to go to sleep is either there's a sleep association, meaning they need that special whoopee, that special person, the rocking to sleep, or it's limit setting, which is that they need the right social construct. So what happens when that child is that repeat kind of curtain call, hey, mommy, I need another drink. I need another kiss. I need another. How do we then frame it as a parent? Stop being a bad child. Stop being a bad child and listen to mommy, listen to daddy, because you need to go to sleep. Sleep is important.
Right.
So now this is creating a construct that if I don't sleep, I'm bad.
Yeah.
Right? So there's shame there. Now what ends up happening is that's your own self-fulfilling prophecy. Unfortunately, the main marker of a child getting poor sleep has actually absolutely nothing to do with the sleep characteristics. It has everything to do with how they are during the day. And so one of the things we see in early childhood is very frequently that impulsive, emotionally volatile child who is hitting, they're biting, they're reacting, they're not taking the appropriate cues. And so now, not only are you the bad child because you're not going to sleep, you're the bad child all day long.
Right.
You need to go to sleep, little Johnny.
Right.
Why aren't you going to sleep? Listen to mommy. And why are you punching your sister? Why are you not listening to the preschool teacher? And so we've created this self-fulfilling prophecy of that you not sleeping, you are the bad child. There is all the shame in the world around even recognizing, considering intervening on those sleep parameters, because now you've been characterized and stamped as the bad kid.
You know, I was thinking about back when I was in kindergarten, and I literally went to a kindergarten class where we had nap time. And I don't know if that's a thing now. I don't know if that's popular now, but we even had our own mats. And we laid it, and I could never go to sleep. And my mom would have to come pick me up. And it all just came back to me when you started talking. And I was labeled a bad kid because I couldn't fall asleep. And I think back then, again, I'm almost 50, they probably would have labeled me ADHD. And I'm talking about even all through my formative years. But I was just thinking about that. And then that same child goes to school and starts falling asleep at school. If they do fall asleep at school while they're trying to learn, then they're like, you're a bad kid. So I can see where the shame comes in for what age group we're talking about, from 5 to 9, 10, 11, where you're like, oh my gosh, they can't stay awake, they can't focus, and then they get put on medicines, and then it's just, so I get where this shame would come from.
And some of that shame is actually coming from a lack of knowledge and awareness of what are the appropriate expectations around sleep. Because sometimes our expectations can go on a swing very wildly from one end to the other. So when you're talking about, like, I'm hearing you telling me a kindergarten class where there's nap time and I cringe. Why do I cringe as a sleep doctor? Because if you're familiar with the normal ontogeny of sleep, what does that mean?
That's why I said I don't even know if they do that anymore.
Yeah. So the normal ontogeny of sleep, that means the normal developmental milestones of sleep. They overlap also with what the normal developmental milestones of neurodevelopmental expectations are. So when you're talking between the ages of 0 and 5, and so that's preschool and beforehand, there is a very, very appropriate change in not only the number of hours of sleep, but also the appropriate fragmentation of sleep. In that first year of life, we're expecting that a child is not sleeping all night and awake all day. Although as a new mom, and we've talked about this in other podcasts, we would love for that to happen because I'm completely sleep deprived because my babies weren't sleeping through the night. But that is very, very important because sleep is a critical component of the learning process. And without it, we are not going to be our optimal selves.
So that even made me think of the parent now. Would that parent feel that shame because that kid's falling asleep and now they're blaming the parent? They're going, what are you doing at home? So again, bringing that
100%.
Wow.
There's shame all over. But going back to when you're looking at the first year of life, we now then move forward. What happens when we move forward is that we see that we do have this natural shift to sleeping at night and then having daytime nap. In that kind of 2 to 3 age range, we usually see going down from maybe it's like 2 to 3 naps down to 1 nap. By the age of 5, no one should have daytime napping. That napping should go away. So if you're in a kindergarten setting and you're still having nap time, number one, please take a look at that because that is developmentally inappropriate to be scheduling that. Preschools, I can tell you, still are doing that. And the reason that they're doing that is because there are biologically children who may still need that daytime nap. My daughter is very much like me. She's wired just like me. I'm sure she's going to be ADHD diagnosis at some point, just as I, as an adult, have been diagnosed, right? And the reality is that during that preschool nap time, she didn't know what to do with herself. So she would lay there and she tried so hard to just be quiet and just, and she was so worried about doing it. Like, it brought her anxiety that the other kids are able to sleep, I can't sleep. And that is a lot of emotional milieu for a 4-year-old to experience and to process and to understand. And when adults are telling me to do something, and I'm a kid who I just want to do what the adults tell me, that how do you navigate that? And I do think that if there's kids in your class who they needed the nap, but then there's other kids that don't force them to be in a situation that makes them feel negatively about themselves or that is malaligned with what their sleep needs are.
Right. I think, you're doing some incredible work, and I don't want to miss an age group, so I apologize. We're talking 0 to 5, and then you got into
well, so now you start moving into like the older child and adolescent, and so what we're now then seeing is that there's also this shift of that there are more and more teenagers who are getting insufficient sleep. So if you look at the most recent CDC statistics, it says 58 to 73% of middle school and high school students are having at least insufficient sleep. So we have right here the International Classification of Sleep Disorders Edition 3, the text revision. You can see how thick this book is. The reason why it's so thick is because there are over 70 different types of sleep disorders that actually exist. And so when you're talking about insufficient sleep syndrome, that's one of over 70 types of sleep disorders that may exist. Now, with that stated, we now are saying that we have 5 to 7 out of 10 kids who are getting insufficient sleep. No wonder they're tired. And there's many reasons as to why that is existing. Most of the media is going to force you to just totally focus on delayed school start times. And the reality is that is one thing. But when you actually look at what is driving the insufficient sleep, it again is one of many, many factors. I recently had done a post on TikTok. It now has over 50,000 views, and we had 600 plus comments on it. And so then, of course, me being a researcher that I am, I wanted to do a statistical analysis. What is the frequency of a school start time being called out? So although it was one of the top 3 reasons, it wasn't the top reason. The top reason actually was features of sleep-wake disorders that people were describing. The second was school start time. And the third was the amount of work that kids were doing. When I looked at all of the responses, what it was a 4-to-1 ratio of every 4 things that were not a school start time to school start time. So just really saying we need to broaden the conversation. However, how does this look in school? It may be kids being late to school. It may be the kiddo who's falling asleep in school. So now you're someone who's late and you're falling asleep. How do you think you're being viewed by society?
And yourself.
Yes.
Because of the words that a teacher or the principal or they're calling the school counselor wants to talk about problems.
And the challenge is that those kiddos end up being labeled as lazy, as stupid, not trying hard. They're only falling asleep because they're bored. The call to action that you need to hear is boredom doesn't make you fall asleep.
That's right.
Sleepiness makes you fall asleep. So if you are falling asleep inappropriately, so you're falling asleep in a class or on a school bus as you're going to school or coming home from school, in a car, and after a little bit of a drive, trying to read a book, those are all signs that you're sleepy. And so sleepiness is a result of either insufficient duration of sleep, poor quality of sleep, or that you're not getting it at the right time of day. Maybe you have a circadian problem. And so the reality is that when we mislabel individuals because of a symptom that they're experiencing, that is not bringing them any further along their own personal journey to actually being their optimal student experience, social experience, etc. I don't know about you, Matthew, but I know that when I am not getting the right quality of sleep or the right amount of sleep, because we all have reasons why that can happen, I am not the same person.
Agree.
I am not able to speak as well. I definitely have word finding difficulties, but I also am a lot more emotionally volatile. I'm going to be more likely to have a negative reaction to people in things that normally I'm like completely unfettered by. But then I'm being a person who I don't even like. And so if I did that chronically, what would I start to identify as? Depressed, anxious, and a variety of other characterizations that are just mislabels.
A Karen. I'm sorry. I'm just... Well, and I got to know your husband a little bit, Eric, and I know that he was one of the motivating factors behind what you're doing. And so when we get into that adolescent stage and we get to that, you're doing something that I definitely want our audience to hear about and working with teenagers. And so please share with our audience about that. I think that this is phenomenal. This is just phenomenal.
Sure. So as an attending physician, being a neurologist and sleep medicine specialist, and recognizing the major gap in people being appropriately identified, I wanted to start providing more education. So in 2018, I started just saying to schools, hey, I'll come and speak to whoever will listen to me about sleep. And so I had the opportunity to talk to school nurses, to teachers, to students, to parents. And there was a resounding theme. Just as the statistics have been showing by the CDC of that sleep is a very, very frequent problem. Everyone was saying the same thing. I give a lecture about something and they're like, oh, I have this sleep problem. I have that sleep problem. And looking for sleep tips, right? And a lot of it was driven by the fact that they thought it was normal. Or they had shame to acknowledge it. And now they're in a situation of that.
Addressing.
This is okay. It's acceptable to have this conversation. So based on that, I then was able to partner with a guidance counselor at a school district. And I'm going to give her a specific call out because she is the most amazing human I know, Denise Liscombe. She's a guidance counselor at Montgomery School District. And she is so invested in the children she is a guidance counselor for. And so she had developed a day called Healthy, Wealthy, Wise. And that day was focused on bringing in speakers to talk to each grade level between 7th and 12th for things that were appropriate for them. So I got to speak with the 7th graders that year. From that was, again, a positive reinforcement of like, this is just a gap. It's a gap in education. It's a gap in healthcare. It's a gap in society. And so she and I had come together and I had conceptualized this idea called Wake Up and Learn, which is a school-based sleep education and screening opportunity to be able to help students have kind of that mirror of, hey, I do or I don't have a problem. And then these are the things of where it's related to you as a student. What has been amazing about this is that, number one, the whole point of this program was to establish a change culture opportunity, right? Move us away from the sleep when I'm dead mentality, which my response is you're just going to get there a lot quicker, to one that sleep is a tool to the optimal me. And what we have seen is that the first year we implemented this program, 64% of students and there was an 87% participation rate. So it was a high participation rate. 64% of students who participated had features of problematic sleep. We now have been in that school system for 3 years. They do not have a delayed school start time. They start at 8 a.m. 8:30 or later is considered delayed. The statistics now hover between 42 to 45%.
That's awesome.
When we've done focus groups and asked the students, you know what it was? It was because we designed it as a change culture program. So a lot of times people are like, well, why are you doing these screening questionnaires? That feels a little invasive. We use very low risk questions that are validated questionnaires to be able to identify, are you high likelihood? The reason why we utilize that is I can give you all the education in the world. If you don't think it's applicable to you, you're never going to utilize it. And what the students had said is that it was the aha moment that I didn't know that this was a problem because everyone else is sleeping 6 hours. I didn't know it was abnormal to be sleepy because there's other kids who are falling asleep in the class. And so what it did is it started to be purposeful of like, well, if this is a problem, what is it affecting? The second thing was that the education is never about sleep by itself. It's about sleep and it's about sleep and learning, sleep and sports, sleep and reaction time, sleep and mood, sleep and risk-taking behavior. They then started saying, oh, well, I'm a varsity athlete. I want to get that scholarship, or I'm a straight A student and I want to get into that Ivy League. When they started being able to frame it in something that was relevant to them and not something to curtail.
What's in it for me?
Yeah. Not something to curtail so I can get more done in my day, but actually make me more efficient in my day. It now completely changed the dynamic. And students actually said, I started setting an alarm to say, this is my wind down time. This is a time that I want to plan to go to sleep. These are activities I started doing. So it creates a change.
And I
culture
definitely want, Dan,
way.
we're going to have a link on this podcast. And again, for our listeners, please go to YouTube and follow, subscribe, like. But I definitely want to link some kind of link to Awake to Sleep. Man, I think if you're a school professional and you're listening to us right now, this is amazing. And again, imagine, and again, I grew up in the 80s and 90s, but I was like, gosh, man, I'm thinking of like 3 different guys in my class that always slept.
Yep.
And it kind of became a joke.
Yeah. Think about when we had my husband on.
I was getting ready.
He was saying, I fell asleep in school all the time. And many times it goes in one of 2 ways. You are either identified as the problematic kid, right? Or the parent, or the teacher's like, I like that kid. I don't want to yell at him. Right. So it's either I'm going to make an example of you and I'm going to call you out. I've had patients who I've taken care of where they're now adults and they're finally coming into my care and I diagnose them with things like narcolepsy or idiopathic hypersomnia. And then they reflect on their own personal journey and the embarrassment embarrassment and shame that they experienced of that. They would fall asleep in class, and the teacher would come and slam their hand on there, or, oh, Mrs. Lacey, oh, I guess I'm not that important. And the unfortunate thing is everyone's saying the same thing. You should just get more sleep.
Yeah.
You should just get more sleep.
And I was thinking one of the things that they would tell a person in my class is like, well, if you're just going to fall asleep, don't come to school.
Exactly.
And so that shame culture, then we graduate high school, and whatever career you decide, you could go to the military, you could go to college, trade, whatever you do. That age group, to me, in the last 10 years, I've really, really wanted to focus on. Even when we started the podcast, the goal was, man, I really want to target 18 and up, because I don't feel like there was a lot there. You want to talk about shame. I mean, let's say you're failing out of school and your parents are like, man, you're drinking, you're partying all the time. What if it is truly a sleep issue?
Yes.
And so what are we doing for that age group, Dr. Ann? I mean, I'm so curious about that. I'm even thinking about these poor people that go into the military that have severe sleep apnea, or they have severe narcolepsy. What if they don't catch it, and then now they're in training again? Now I could not imagine.
Sure.
Is there something out there, some statistics we could share or something?
Sure. So I think that what's important is you call out such an important fact, is that when our social expectations change, it starts to more highlight that there's a problem, right? So for that teenager who maybe was falling asleep in school, but still able to get good grades, right? And mom and dad are responsible for making their meals, doing their laundry, etc. They now transition to college, and now this gap gets broadened. It's not that the problem worsened, it's the deficiency in being able to perform at the social expectations have changed. And this is where the shame gets worse. Why is it that I was able to get the same grades as someone else in high school? I'm now in college. I'm struggling to get the grades. I'm struggling to attend school. I'm doing the same thing that the other kids are doing. One of my close friends, and she's a tremendous advocate, Julie Flygar. She runs Project Sleep. You definitely have to check it out. Her whole mission with Project Sleep is to make sleep cool. And the reality is because she experienced that stigma. So she herself has narcolepsy. She was able to navigate college, law school. Is a lawyer, but she remembers being like, why is it that I can't do the same things? And it's, again, all of that self-shame. So some of the things that we really do need to do, and with my program I did for middle school and high school, we do have it in colleges now as well. It is really starting to understand, what do sleep disorders look like? And really start to lean into the fact that when we feel like we're not performing the same as other people, we tend to put these limiters on, not only as society, but also in medicine. If you come in and you tell me you can't do the same thing that other people do during the day, I ask all the questions in the world about daytime things, but I don't ask you about your sleep. Right? That's the way we're trained. The reality is, if you want to look at something like the Nexus registry, which was a international registry looking at individuals who have narcolepsy, they analyzed the data, and they said, what were the top reasons that people ended up going to a physician because of the symptoms of narcolepsy that they're experiencing to finally get a diagnosis. Now, in that journey, they saw 3 to 5 providers before finally seeing a provider who diagnosed them with narcolepsy. But the top 3 reasons, number 1 was excessive daytime sleepiness. They were like, why am I falling asleep inappropriately? Number 2 and 3, or I guess
I got
1, 2, 3,
Just
if I
don't
can
flip
count.
me off.
Yeah.
We're good.
Number 2 and 3, though, were deterioration in work performance, deterioration in school performance. Okay? So I can't do the same thing that I knew I could do, and I can't do the same thing that is expected of me. And so with that comes the shame and blame. And then again, when I'm seeing 3 to 5 providers of people not validating to me that a sleep problem exists, I now further emphasize to myself, it must be me.
Yeah, shame.
I need to work harder. I just am not trying hard enough. One of the first questions I ask many of my patients who ultimately have a diagnosis of something like narcolepsy or idiopathic hypersomnia, and this also is true of people who have obstructive sleep apnea, insomnia, restless leg syndrome, etc. When they're coming to me and going, I can't get the right quality, duration, timing of sleep, I'm feeling horrible during the day, I ask them, what do you think is the problem? What do you think is the cause? You know the number one thing that they say?
What's that?
I just don't think I'm trying hard enough.
Wow.
There must be something something that I'm just not
So
doing the
They
same.
put
They
on
put it
them.
back on themselves. And so it's not uncommon that by the time they come to see me, they're already diagnosed with depression, they're diagnosed with anxiety, they're diagnosed with ADHD, they're on all these medications. It becomes even more difficult to disentangle. And so if you don't have the luxury that I have, where I'm able to spend some time with my patients and really dig in and understand, then I'm going to mislabel you. I'm going to misdiagnose you. And it's not that that's not that was a purposeful malintent. It is that I'm trying to get to an answer for you to put you on the right path as quick as possible. But I'm doing that with the wrong information available to me.
Right.
Both because of the educational deficit, but also because I'm not having the time to be able to go through it.
It's so funny because I think education and awareness, anytime that we bring something dark into the light, right? So currently right now, I'm working with historical black colleges and I'm working with the football program with SomnoMed. And we have an oral device. And so we went down to Southern and Grambling, down in Louisiana, and we, HST, put a home sleep testing on their football program because we believe that, again, like a lot of athletes, we want to optimize sleep, optimize performance. When we got all the results back, it was staggering. Now, these are athletes in college, scholarship athletes. And you would think once we tell them, like, how serious it is, there were some that we were like, they need to see a doctor. Like, they need to go to a doctor. We have a physician overlooking them, but I mean, it's serious. They need to do in-labs and stuff. The shame. And they were like, no, I'm good. Just hand me one of those things. No.
Yep.
So it boggles the mind that there's such this, and I'll speak for what I've witnessed in South Texas, with both companies that I've worked with Philips and SomnoMed, there's this machismo, right? So now we're probably getting a little out of the age range. Now we're kind of moving up, where it's this machismo thing that says, no, I'll sleep when I'm dead. I don't need to be on this. It makes me look weak to be on a CPAP for obstructive sleep apnea. It makes me look weak to wear an oral device. It makes me look a certain way. And again, I think that's mixed in with shame.
Yes.
I really do. Because our ego, right, plays such a big part in shame, because we can't admit, because it'll make us look weak.
Yes.
And so I'm curious, like, what are we doing about that? So even for the pilot that we're doing right now with the historical black college football programs, we're actually showing them the importance of breathing and stuff, but trying to make it, as your friend said, sleep is cool.
Yeah.
Right? By doing this, by knowing that Joe Rogan wears an oral device at night, by knowing that LeBron James uses an oral device and a breathing machine at night because it optimizes performance, how are we getting that message out to the larger audience? And again, I will tell you, also working with truckers and associations with that, you would be so shocked that people just, even when their job's on the line, they just don't want to wear it because it's not cool.
Yeah.
Is blows my mind. What are some things that you can share about that? I mean, just whether statistics or just in general about the stigmatism of that.
Sure. So I'd say subscribe and continue to watch Sleeping Around the podcast, because that is the whole purpose of this, right? Is that not only do we want to destigmatize, but we also want to educate people on the intersection between wellness, culture, lifestyle. It's not just something that you do in a night and then it doesn't touch anything else. It touches every part of your life every single day. The challenges are, I think, that when you look at sleep, number one, we do a terrible job educating in the structured settings for people who need to be educated on this. On average, 3 to 4 hours in 4 years of medical school is what is being utilized in the United States. We're doing a little bit better in some other parts of the world where there's 0 hours, but the reality, when you even look at that as 3 to 4 hours, only about 17 minutes is spent on pediatric sleep.
That is crazy.
When you look at what are we educating on in sleep, we're not talking about sleep and learning. We're not talking about sleep in all of these other medical disciplines. We're talking about, this is what obstructive sleep apnea looks like, because that has been a hot topic for the past 30 years in sleep medicine, right? The second is narcolepsy. Why? Because we look at it as this like unique diagnosis where media has sensationalized it as being a very embarrassing and poor representation. You look at movies like Deuce Bigalow, where there's a character who has narcolepsy or is portrayed to have narcolepsy. And what does that person look like? They look like a non-contributory member of society who is just something to laugh at. And that is so far from the reality. And then we also will look at things like REM behavior disorder, where people act out their dreams. So we take 3 of over 70 diagnoses.
That's crazy.
And we kind of highlight those. And in those 17 minutes, it's mainly for pediatrics, it's mainly put the baby on their back to sleep to prevent SIDS, and maybe, again, looking at sleep apnea. Now, the reason why those priorities boggle my mind is because there is a relationship with sleep-wake health with every single organ system in the body. In fact, you can look at things like the World Health Organization, who has classified circadian rhythm disorder, specifically shift work disorder, as being a carcinogen, a cancer-causing agent. You look at things like obstructive sleep apnea, and it's an independent risk factor, independent of how much you weigh, independent of you having high blood pressure, etc. For things like stroke, myocardial infarction, heart attack, things like you having I'm sorry, I don't know why I'm losing my mind. Maybe I had some sleep.
We're going to be talking about this, erectile dysfunction.
Erectile dysfunction. Yes, you look at individuals who have erectile dysfunction, 92% of them are likely to have obstructive sleep apnea.
That's crazy.
And then if you were to take on the inverse, if you have men who have obstructive sleep apnea, depending on the study you're looking at, it can be anywhere between 30 to up to 70% having erectile dysfunction. And then in addition to that, up to 30% saying that they have decreased libido, decreased interest in even having sex. And so the reality, you come in as a man to a doctor and you say, number one, I feel embarrassed to even talk to you about that.
Shame.
Mr. Johnny isn't working the way that I would like him to.
I'm glad I know what you call your husband's penis.
It doesn't have a name. And so the reality is that you're going to get given a pill. You're not going to have any further discussion around
and
your
now,
sleep or anything else.
You could literally log on, not that I know this from experience, and you can have a consultation and get it sent directly to you. So you're not even dealing with the sleep aspect. And it boggles my mind that it's so prevalent. Those statistics, 91%, that's crazy to me, have OSA, right? The 91%, I want to make sure I'm saying that correct. Again, it goes back to shame.
Yes.
Number one, I agree with you. I totally agree with you. Your husband does not have a name for his penis. That's not what I meant. I totally agree with you that there is a correlation between that. For a man to go inside and have a conversation with a therapist, all that, it's been such a stigma, right?
Yes.
That I got this machismo. I can handle it. My father handled it. My grandfather never did this. The Great Depression, they didn't have all this.
Yes.
But at the same time, when we're asking for help.
Yes.
So we're a society, I believe we're getting better now, where we're actually looking into the issues. What cracks me up is that when we're told it's related to sleep, when we're presented with an expert, as you are, subject matter expert, and told what to do, the compliance it's just not there. And these statistics have stayed the same.
Sure.
50%. It has stayed the same since they very first launched the CPAP till today. Sure. 50% of people stay on CPAP, period. The other 50% don't. So that's why there is other options out there, which we've talked about in prior podcasts, whether it be an oral device, whether it be Inspire, whether it be just different options. But could you imagine that other 50% doesn't do it? There's a percentage of those that just don't because I don't want to. It doesn't look cool. I can't have my babe in bed with me and put on a mask and play Maverick, you know? Sure. But not realizing they're literally cutting off minutes and hours of their life by not treating a
well, I mean, I think this also goes back to just when I was talking about the program I developed of that if you're trying to create a change culture, you can't just give education alone, right? If I just give you education on this is why you should utilize it versus I give you education then plus tools. So those statistics that you're quoting about CPAP adherence is based on, so typically it's that within the first 30 days, we'll see that maybe there might be 30% who stay adherent, right? Wow. On average, we'll see in most sleep practices that 30 to 50%. The reality though is if you are a sleep practice, so I had described this earlier of how I use my sleep psychologists, of that I use them for that CPAP desensitization, making sure they stay adherent, etc. Those statistics are 70 to 80, 90%.
So of staying compliant on CPAP.
So the reality is that when you're giving education alone, you're right. You're going to see people fall off. When you're giving education plus tools and helping to personalize it to your journey, you're now going to be more successful. So you described someone like LeBron James, where he's using an oral appliance and a CPAP. Yeah. Well, why? Breathing machine, like, is one not enough? Well, you know what happens is that helps in modifying how much pressure I actually need on a PAP device. It's the same as when I have an adult patient who I might need to give a CPAP to, and when I do the titration, I need to get them to a pressure of 12. So we start at 4, and we incrementally increase to make the breathing problems go away. 12 is a pretty significant pressure. So can you imagine laying in bed and there's something that's like, that's a pressure of 12. When I then send them to the ear, nose, and throat doctor or to the dentist and say, are there things that are modifiable to improve the airway dynamics? I now, again, am personalizing it to them, and I'm responding to what they're saying. The challenge that we're seeing in medicine is that you are most typically dealing with the fact that there still is this major educational gap that people don't know how to respond to. They don't know what questions to ask. They don't know how to then respond. If they ask the questions, they don't know how to respond to them. And most typically, what is the standard response? You should get more sleep and improve your sleep hygiene. So if I'm coming to you and saying I can't sleep, and your response is, or I'm too sleepy, and your response is you need to get more sleep, that doesn't help me. Where do I start? How do I do that?
Well, I liked what you said about the child. I didn't like it. I was blown away that I never thought about that. But when you were talking about working with children, they said, I'm just not trying hard enough. And it just goes, just so they take it,
Yeah. And that's not just a child's response.
Okay.
Many adults have said that to me, that I'm just not trying hard enough. I must not be doing what my doctor said good enough. I'm not using sleep hygiene well enough. And the reality is that that's because you've been presented with a farce. Sleep hygiene alone doesn't fix sleep problems. Sleep hygiene helps prevent sleep problems. And so the reality is that when I'm misdirecting you and you're trying all your might and I'm giving you recommendations that actually aren't going to fix your problem, you're going to continue to have a problem. And then how do you identify that? Then I must not be doing well enough. The analogy I always like to give is the people for weight loss journeys. We all can identify that at some point in time about a weight loss journey, right? If you're a person who I just tell you, eat less. Eat less of what? Eat less cookies, eat less salad, eat less. Eat less. You really should lose weight.
Right.
How do I do that?
Right.
What should I be eating? How frequently should I be eating?
Right.
When should I, what, is this enough food? Is it not enough food? And so when you just give people sleep more, good sleep hygiene, we now then say it's a failure on me. And so we see this, if you were to continue on that kind of age trajectory.
Yes.
We talk about obstructive sleep apnea, for instance, and then compare it to something like insomnia. I say obstructive sleep apnea. Who's the person that comes to your head? What does that clinical description look like?
Well, male, over 60, overweight, BMI over 20. Yeah.
Exactly.
Yep.
So, and I say insomnia, who comes to mind?
Well, now the Deuce Bigelow thing, because you put it in there.
Well, no, that was narcolepsy. Insomnia.
Sorry.
Insomnia, most typically people will say woman, right? A
Really?
woman.
I don't think that.
So women are more likely
Really?
to be diagnosed with insomnia. And so many times we'll start to say women, and then as we age, that may be a higher likelihood.
Okay.
Now, this is the problem with those imageries that come up, right? So I very frequently use these types of challenges when I'm giving talks.
I love the statistics.
And
yes.
so the reality is that I'll tell people, I'm like, think of this diagnosis. What comes to mind, right? And there's very, very clear depictions that come to mind, right?
Okay.
So I'll give you an example. At a recent talk I gave, I had said, multiple sclerosis, what comes to mind? And so I then followed up with, I'm sure you envisioned an individual who had an obvious physical disability.
Yeah. Well, I thought of someone I know.
Yep.
Yeah. Family member.
And that's the thing, is that we all know someone, or think that we at least know someone who has multiple sclerosis.
Right.
I then said, narcolepsy, what comes to mind? And so many times people will have that imagery of someone like the Deuce Bigelow, falling asleep in their soup, falling down steps, etc. Like that, it has to be so obvious. But you don't necessarily think about it as a disability.
It's true.
You also don't think about it as it's likely someone you know. And so I then follow that up with the same socioeconomic disability, the same medical disability has been shown to exist in people with multiple sclerosis as in those who have narcolepsy.
Wow.
And although you probably, just as you just did, said, I know someone, my mom, and that's the reason why I'm in medicine. You then are also completely dismissing that you likely know someone who has narcolepsy. The statistics of multiple sclerosis is 1 in 2,000 people have multiple sclerosis. The statistics of narcolepsy is 1 in 2,000 have narcolepsy.
Wow.
So the reality is the same that you were able to go, I have first, second, 3 degrees of separation to that, right? Is likely that you know someone who you have 1, 2, 3 degrees of separation. You now move forward and you say, let's look at things of something like obstructive sleep apnea, where even in medicine, we have validated scales that we use in clinics, like the Stop Bang, like the Berlin, et cetera. And you know what they do? They do a very, very good job of identifying overweight men who have hypertension and snore
comorbidities
to have obstructive sleep apnea. You know what they do? They further limit the diagnosis of women and people who don't fit that phenotype of actually being diagnosed. And the reason why that's so erroneous is because when you look statistically of who has sleep disorder breathing, it is a 2-to-1 ratio of men to women when you're looking at the 18 to 50-year-old range. When you hit 50, it actually flips, and it's a 1-to-1.
I love that statistic.
And the reality is that the reason for that is 100% biologic. When women are entering their 50s, and even for some women, it's before that, we're entering perimenopause and menopause. And so again, remembering that sleep affects every single organ system, and every single organ system has the potential of affecting sleep. When we have those drops in progesterone and estrogen that we're experiencing with menopause, it actually increases the likelihood of having a more floppy airway and you experiencing sleep disorder breathing. You want to know what happens when these women end up going to their physician and complaining of difficulty staying asleep or waking earlier than desired? You're depressed. You have insomnia. Here's a sleep med. Here's an antidepressant.
Well, I was going to say it's usually Xanax.
Yep. And so what happens when I give someone who has sleep disorder breathing a Xanax, which is a benzodiazepine, which is going to relax my muscles? The muscles that are not excluded from that are my upper airway muscles. So you know what ends up happening is it works temporarily because it knocks out the brain, but it's exacerbating my breathing. And so now I have worsened sleep disorder breathing. And now I do have anxiety. I do have depression. I do further stigmatize myself as being someone who there must be something wrong with me, right? And so this is a major challenge. We see this being perpetuated across many different areas, and people not being willing to have these conversations with their providers or even with other people because they feel like they're weak. If they say, I can't sleep and I don't feel like I'm optimally functioning during the day, because they have peers who are going, well, I only get 5 hours of sleep. I only get 6 hours of sleep, right? And we've said this on other podcasts. 2014, the CDC said, sleep disorders in the United States, major public health crisis. We see that it's affecting 1 in 5 adults. We now see those statistics only worsening. They're now saying that it's probably closer to 1 in 2, 1 in 3 adults, especially as we're having advancing age and increasing medical or psychiatric comorbidity. It makes it much more likely for you to have a sleep disorder. However, we're still wearing it as a badge of honor. We're still not diagnosing it. We still are not seeing changes in curriculum or governing bodies. And you know what we're doing in the sleep field? We go to sleep conferences to talk to other sleep people about why sleep is so important, but we're failing to meet society where we need to change these dynamics, and failing to meet other organizations for them to start saying, listen, when you're seeing your cardiology patient, when you're seeing your endocrinology patient, when you're seeing your neurology patient, remember that nighttime sleep time is a part of their 24-hour day and is also a representation of how well you're managing them.
I think when it comes to shame, one of the things that we visited before the podcast, and I had mentioned in a previous episode about my sleep hygiene and some hacks and some things that I do. You mentioned something pretty cool to me that I never thought about. I think with shame, it's about bringing it out to the open, right? Bringing it out to the light. You have this right here. It's a 90-day journal. You want to talk about it a little bit? And I think that if I was able to get one of these and then kind of go through, would that help me then as a person who wasn't sure I wanted to talk about my sleep issues? Is this something, or a tool like this, would this be helpful?
So before I even say anything specific about this, one of the things that I will always tell anyone who will listen is the more that you're able to understand your own life experience, the better you're able to communicate it with your partnering healthcare provider, right? And so one of the things that I advocate for very, very frequently is journaling. Why? Because it helps you to understand what your trends, it gives you your own objective data to come to your physician and have a meaningful conversation.
Absolutely.
When you come and you say, I just don't feel good. I just don't feel like I'm sleeping well. There's so many
My
ways
wife made
to
me come. She says I'm
there's
not.
so many ways to interpret it. When you start utilizing any type of tool, and it doesn't need to be this book, it can be your cell phone, it could be an
Right.
app, it could be
Right.
you just taking an old school pen and paper marble notebook and taking some notes. The thing I like about this particular journal is that it's a 90-day journal for mindfulness, self-discovery, and better sleep. Again, making sure that I'm reinforcing this concept that you can't disentangle your daytime from your night. Right? It is a 24-hour you. And for you to be better able to understand that, whether you're a person who's perfectly healthy, has no concerns, or you're a person who's suffering from migraines, seizure disorder, you have high blood pressure, you have low thyroid, you have diabetes, understanding your 24-hour trends is only going to lead to more optimal treatment options that may extend beyond just increasing your medications.
Absolutely.
And so with this, it not only is a journal where you can just record your morning and night, but they also have specific areas that help you with actually doing tasks. So
Wow.
this one, for instance, forming great habits, going over what you can do to actually make those meaningful changes. And so for me, I always am very, very much a fan of opportunities where you have improved self-awareness, because that only allows for you to be in a driver's seat as to what are the goals that you have in your healthcare journey, in your sleep journey, whatever it is that you're trying to tackle. Although I have the medical training, I have the medical expertise, I don't have the you expertise.
Right.
And so when you come fully empowered and active in your journey, you're going to have much more better outcomes, even if you're meeting with someone who may be insecure with their own sleep medical education. It now allows them just to be more specific on how to potentially direct you. It may prevent you from being that person who has to see 3 to 5 providers before actually seeing the right one who's going to be able to help you get on the right track.
If you're listening to this podcast or watching this podcast and you're just at your wit's end, our challenge as a podcast and as a team is start asking those questions. Start asking the right questions. Go see a provider. Go see a counselor. Talk to your spouse. Talk to your friends. I think the more to get it out there, because there is, with shame, I believe, like just keeping everything to yourself and feeling not good enough, or this view of social awareness that is not there, right?
Sure.
Like, I don't want to be judged. Feeling better will get there when asking the right questions.
Yes.
I find that in part of my job and in my career has been to really motivate and to kind of walk with not only physicians and dentists, but also that patient. Because being a person who has been married to someone who has severe sleep apnea and OSA and had been on machines, I mean, I know the journey.
Yes.
And I know that there was many doctors who said, put poor Kelly on every single medicine where her hair was falling out. She was losing weight. She had tachycardia. She had all these issues that were because of not sleeping. And
Yes.
so I guess one of the reasons I'm so passionate about it is because I've lived it. And it wasn't until we had, by the grace of God, that we had the right doctor go, have you done a sleep study? And I remember we were at our wits' end. We had done everything.
Sure.
We had done a full body scan. We had gone to Mayo Clinic. We had done everything. At one point, we thought she had cancer. And it literally took a freaking in-lab study. It literally took, this is before HSDs and stuff, but and so because I lived it and because I know that person so well, still today I know that person so well, she would have never have
Yes.
just overtly asked. So that's kind of the challenge. Like, go out there and just ask the right questions.
Sure.
When it comes to sleep, I think the perception is I'm going to have to go through all this and it's going to cost money and it's going to do this and that. And help one of our listeners right now, if they're having one of these issues that we've talked about, whether it be narcolepsy, whether they feel like they're just tired all the time,
Sure.
daytime sleepiness, what is their first step? Let's just start right there as we're ending up this podcast.
Sure.
One thing they can leave with, what's the first thing you would tell a patient to do?
So I think first
Listener to do, sorry.
Yeah. So first and foremost, I think making sure you're really characterizing for yourself what your concern is, because that's only going to better crystallize for the healthcare provider that you're working with. One of the things I'm doing at my healthcare system is I'm creating a very novel program called Sleep to Be Well, which is an integrated model of sleep education and screening, similar to what I did with the school systems. We now even have, if you were to come to my healthcare system's website and come to that landing page, we have the screeners right there
Bam.
that will help you to characterize, do you have high risk sleep behaviors versus lower risk sleep behaviors? the thing that I'm creating that's completely novel is that it's completely agnostic to where that patient is in their journey. But we now have a command center to help that person navigate it. And so one of the things that I'm hoping to do is to continue to scale that program, not only to be available at my healthcare system, but anywhere in the country. And the same thing for Wake Up and Learn. And so the reality is that even if you're not in my state, you still can go there to be able to start that medical journey, because we have lots of information. We have lots of tools to help you to start characterizing the things that you're concerned about. What I would say to you also is that many times you get discouraged as a patient. Don't go and Google. Don't mistake your Google search with my doctoral degree. That is one phrase that is so cringeworthy to me and just like makes my hackles go up, because basically you are disempowering anyone without a medical degree to do their own self-education and bring to you a more purposeful conversation about what they're experiencing. So I would completely go the opposite way. If you have concerns about sleep issues, there's a ton of not only advocacy organizations like Project Sleep, but there's also the American Academy of Sleep Medicine has sleepeducation.org, which is a patient-facing or a public-facing resource. The Sleep Research Society has tremendous resources. There's a variety of different disease-specific resources as well.
And we need to put those on the bottom, because we want our listeners to basically go there and just click on a link, because what you were saying with AASM, they're able to find a provider inside their town. You can even will it down to if you have insurance or don't. And these are board certified in sleep. And besides winning the award, the very first annual Matthew Allard Award, and besides looking very lovely, and besides
having amazing shoes,
the butterflies, besides, sharing about shame, besides your sleep expertise, and now I know that your husband doesn't name his penis. I want you to leave. You want me to leave? I'll leave. No, I want you to get the heck. I want you to leave this podcast. I want you to leave our listeners with one good, funny story. We have gotten so deep this, or a success story, not funny story, success story. Can you paint a picture real quick of someone who came to you, that person that we're talking about, that came to you was like, I'm just, they were shameful, and then they had success. Could you? Sure. And then we'll end the podcast. But I want to end on like just something, positive.
Sure. So there's a lot of those stories that do come to mind, but
that makes me happy that there's a lot.
But the one that I think I'll share is that there was a single mom. She had a now teenage son who had very severe autism spectrum disorder. He's nonverbal. He behaviorally is just such a sweetheart of a kiddo, but he doesn't sleep. And so when you have a child who has autism spectrum disorder, who is nonverbal and not sleeping, you're constantly worrying about what they're going to get into in the middle of the night. So when that child's not sleeping, no one is
sleeping.
Mom's
not sleeping,
Mom had gone this journey, had gone to a variety of different centers, including some very, very high-performing quaternary centers, so kind of falling into categories of like a Texas Children's, a Boston Children's, a Children's Hospital of Philadelphia, and had never been able to actually move the metrics in regards to the sleep. She had come to me with the request for a sleep study. So she had come to my clinic. It was with my sleep fellows, and she said, I just think that he needs a sleep study. And so I do the whole history. My fellows actually did the history first, and I come in and I hear what's going on. And I said to Mom, I know you came here for a sleep study, but I can't give you a sleep study. And she looked like she was going to be in tears. She's like, he's just not sleeping. I don't know what to do. And I said, the reason why I can't give you a sleep study is you came to me because he's not sleeping. If I put him, who has autism, who has sensory integration, it's not going to tell us anything. So I'm not taking it off the table. I'm just telling you that not right now. What I would like to do is I want to get you into our sleep psychologist, because she already has such great sleep hygiene, structure, all these. And I said, I would also like to offer you a medication. Now, with these types of situations, medication is not always utilized. And children with autism spectrum very frequently need to use medication. We gave the medication. We gave the behavioral strategies. We had her with sleep psychology. The very next visit I had with her, it was a telemedicine visit for the next visit. We start the visit, and Mom just starts crying. And I'm like, oh, no, are we doing such a bad job that it's gotten that much worse, right? And Mom goes, You've changed our lives.
I love that.
You've changed our lives. He's
You've changed
sleeping.
our lives.
He falls asleep. He stays asleep.
Oh.
And so my question for her was, do you think we still need the sleep study right now? And she
Yeah.
goes, no, we know. And so it's not just saying that someone needs a sleep study, because that's
agree.
not always the answer, right? It is selectively choosing how to partner so that you're treating the person in front of you. And he may need a sleep study at some point.
Sure.
Children who have autism are much
Yeah.
higher risk for sleep disorder breathing than children without autism. However, where we are right now is in a monumental different place.
Wow.
And that mom, when she first came, had so much shame because she
Yes.
felt like, I'm not doing enough for my son, and I'm shameful.
Yep.
I feel also shameful for wanting you to do something different because it's disruptive to me
Right.
and our household and my other children. And so being able to see that evolution, that it's not shameful. I'm so glad you're here. You are doing the right thing because this is benefiting his health. And then getting to the point where you're met with tears of joy
I
because
love
we're
it.
on the right direction is really what it's all about.
I see. That's how I want to end. And so,
So now I can leave.
no, thank you for sharing that. And listeners, again, like, subscribe, share. Again, the links will be below. And thank you so much. And thank you all for sleeping around with Dr. Ann and Matthew.
Just keeping it between sleep friends.